Microvascular angina, definition, diagnosis, and approach and treatment that will be dictated by Dr. Andreotti.
It's a pleasure to be here and to talk about this topic, which is fascinating but complex, in my view, at least. So I will raise some questions, and I would like in the discussion that you perhaps try to provide answers. I don't have a disclosure slide. I apologize. I have some links with a PCSK9 inhibitor and with companies related to direct oral anticoagulants. So I believe nothing related to this talk. Now, what are we talking about? Microvascular angina. And here is a very compelling picture, because we have the traditional angiogram that shows what we're very familiar with. And then we have a post-mortem bismuth contrast angiogram that shows what is behind, what is missing. And it's no surprise, we all know that to perfuse a tissue, you need the microcirculation. This is my outline. And is this issue of disease of the microcirculation clinically relevant? So the suspicion came when, about a decade ago, it was found that the scores that Professor Magdi talked about were not able to predict in symptomatic patients a pathology. They were designed to predict obstructive epicardial disease. But here you see, even in those that had typical symptoms, the expected diagnosis of obstructive disease was much higher than the observed in gray. So there was something missing. These patients had symptoms, but they did not have epicardial obstructive disease. If anything, the less typical the symptoms here, the closer was the ratio between expected and observed. So this raised suspicions and also raised a few questions. Now, one reason why nowadays the pretest probability scores based on age, sex, and typicality of symptoms, and now additional risk factors, perhaps coronary artery calcium score, are less predicted than before is because we're testing lower risk populations. Now, we are well aware of the menace of obstructive coronary disease, and therefore, when we reach a certain age, we go to CCTA to rule out, et cetera, and then even if we have moderate symptoms. But I think we indeed acknowledge that we need to recalibrate these scores, because probably thanks to the effective treatments of hypertension, lipid lowering, et cetera, antithrombotic drugs, but basically prevention of atherosclerosis, probably in the Western world, obstructive coronary disease is declining, fortunately. And we need to recalibrate the pretest likelihood test for obstructive disease in this sense. We also need to redefine symptoms. In fact, the Americans are disliking the terms typical, atypical, non-anginal chest pain, and they're saying cardiac, non-cardiac. So this is an evolving scenario. And then, of course, the topic of today is to consider other possible causes of chest pain beyond epicardial obstructive CAD. Another reason why it's come to our attention that it is a clinical problem is what Professor Lozano showed us, and that is that ischemia trial, one of the most contemporary, took patients that had evidence of at least moderate ischemia on non-invasive testing, and 20% were found to have an absence of obstructive CAD. And these are other registries that go in similar directions and show, particularly in women, how the prevalence of non-obstructive coronary artery disease in patients who are nonetheless symptomatic can be indeed very high. So let's go into how nowadays we're trying to define these syndromes. Definitions, I put a plural because I think there's, you know, if you take one paper, it tells you, you know, look at impaired coronary flow reserve. If you look at another one, it will orient towards vasomotility testing. If you look at another one, yet it will be microvascular resistance. So I've done my best, but you're here to be critical and in the discussion to give your ideas. So, you know, the simple definition is one based on terminology, microvascular angina. So it's someone who has chest pain and presumably of ischemic origin, not related to epicardial obstruction. And therefore, I would say myocardial ischemic syndromes without neither epicardial spasm or obstructive coronary artery. And I think we all agree this is quite simple. So then we have angina with what by it's not epicardial, is presumably microvascular disease. We exclude obstructive coronary disease anatomically, and we have angina with the non-obstructive coronary arteries, or what I would introduce as another side of that side of the coin. Anorca, for instance, angina with normal, completely normal, because this is an important distinction, I believe. If you have diffuse atherosclerosis, which is not stenotic, about 50%, you're at a higher risk than having completely normal. But traditionally, we have angina with a functional test that tells us that there's ischemia, inoca, not anoca, inoca. So. And I would say, and again, you need an anatomical test to exclude epicardial and distinguish non-obstructive or normal coronary arteries. You might even have an asymptomatic individual who undergoes some sort of non-invasive testing, presumably, and finds evidence of microvascular. So basically, it boils down to how we define microvascular disease, right, in our clinical setting. And here, for instance, Covadi's diagnostic criteria define microvascular angina by the presence of symptoms of myocardial ischemia, non-obstructive coronary artery disease, and proven coronary microvascular dysfunction, which in turn is any abnormal IMR. And we're beginning to be a little bit, oh dear, what does IMR mean? So it's index of microvascular resistance, coronary flow, so it can be abnormal resistance, abnormal coronary flow reserve, or microvascular spasm to acetylcholine. You know, so then you really need to go into these details to finally conclude what does the patient have or not have. I'm very happy that in the past, it used to be defined non-invasively as abnormal coronary flow reserve, but we're increasingly appreciating that that's part of a hemodynamic abnormality. So I'm happy that the interventionists have introduced resistance, which is related to absolute flow, because flow, what is it? From my recollections, the ratio between pressure and resistance, whereas coronary flow reserve is a capacity to dilate from basal. But you might have someone who's chronically vasoconstricted who dilates very well, although chronically constricted has a low blood flow at rest. So it's more complicated in a way than I think, well, what I'm saying, we need to take into consideration all these elements. Now, a true anatomical definition is not to exclude something, but to try to look into what we're talking about. So what are we talking about? We're talking about the microcirculation, everything that is below 0.5 millimeter, 500 micrometers, the pre-arterioles, the arterioles, and the capillaries that Giuseppe showed, where the single blood red cell can flow or not flow if it's already obstructed, if it's destroyed by fibrosis, if it's ratified by hypertrophy that reduces the capillaries compared to the mass that it use. And please note that this is the part where you have vasomotion being important in terms of dilatory capacity, coronary flow reserve, or in terms of chronic vasoconstriction or chronic vasodilation. You have, or segmental, regional, there are many variables. Now, a mechanistic definition of microvascular disease is quite classical by now, and it still holds true into structural, meaning diseases, hypertrophy, risk factors, in particular, aortic stenosis. Functional, referring more to the vasomotility component, or indeed extravascular because of compression, for instance. Please appreciate how the risk factors here seem to be playing an important role: hypertension, smoking, hyperlipidemia, diabetes. So the questions that may come to mind is microvascular dysfunction just a reflection of burden of the traditional risk, atherosclerotic risk factors? Is it a precursor, as it were, of atherosclerosis? In which, also, what is missing from this sort of mechanistic definition? A simple diagnostic tool, in my mind, and a unifying, presumably hemodynamic abnormality. The clinical definition is what we, those that don't do the invasive testing, for instance, you have the woman with angina, non-invasive functional test indeed shows ischemia. And then you go to angiography or other anatomical tests, you show that there's there's non-obstructive coronary artery disease, and you're entitled to say that this is a picture of INOCA, angina, ischemia on non-invasive testing, and non-obstructive epicardial arteries. Now, what is missing from here beyond the detailed assessment with the acetylcholine, with the IMR, with the CFR in the cath lab? Another element is missing from this typical picture, and that is ANOCA. Is ANOCA present? Does it exist? Well, yes, the patient that comes with chest pain wants to know if it's ischemic or not. And in some cases, for instance, we'll show the abnormalities are found if you look in depth. However, one must acknowledge that this position paper that is considered quite a reference in 2020, and it is an advancement in the effort to sort of unify these complexities, discussed, I'm sure they discussed at length how to entitle it, and they chose to define ischemia with non-obstructive. They chose not to consider NOCA. Should we consider ANOCA? Is it more modern? This other piece of paper, paper, the reference will be elsewhere, apologies, but it's called ILIAS Global Registry. Here it is, yeah. It's more recent, and instead they included ANOCA. They took all patients with angina. They took those that had ischemia on non-invasive testing. They also investigated those without ischemia on invasive testing and did all the details and found that a group had coronary microvascular dysfunction. Now, interestingly, these did not use the acetylcholine test. So, I think we need to do a big effort of trying to clarify, of summarizing what is out there. Now, in my view, I may be wrong because, as I said, I'm more a thrombosis person from my background. We may be able to improve yet further in trying to introduce a unified hemodynamic abnormality that characterizes every patient: ANOCA, INOCA, resistance, flow reserve, etc. And that is coronary flow capacity, which is defined in a very, by Lance Gould, also in a seminal paper that goes back several decades, but also here, as maximal absolute flow in the myocardium plus coronary flow reserve capacity. So this is, can we measure this? Yes, we can, because we're used to measuring coronary flow reserve as the delta between hyperemic and baseline. And flow, we can measure it by velocity, because flow is not only pressure divided by resistance, but also is velocity times the cross-sectional area. So if we have the diameter of the vessel and the velocity, we can stratify capacity, flow, coronary flow capacity into these areas that do have prognostic meaning, and I believe might represent an important step forward. Diagnostic approach. Mani nei capelli, I would say, because this is my approach. Then, okay, diagnostic approach. So the accurate, precise, modern diagnosis of microvascular disease is based on these three items, the combination, because we said coronary flow reserve might be normal, but you might have increased resistance. And this is another item that I think is similar. Here are the abbreviations, and they are specifically reflecting microvascular indexes, or once you've excluded FFR, epicardial component, you can attribute CFR to microvascular disease. What are the steps that are advised in a modern diagnostic algorithm? The first step is to exclude flow-limiting epicardial disease through traditional angiogram or even through non-invasive CCTA. The second step is to assess microvascular disease or not. And the third, through coronary flow reserve and IMR. But then there's the third final step, that is acetylcholine testing for vasomotility at different levels and at different doses. Basically, you start with low dose acetylcholine, and if you have an entirely normal vasculature, you're meant to vasodilate. If instead you vasoconstrict with low dose, you're entitled to diagnose endothelial dysfunction. At higher doses, you go into a range of vasospasm or vasoconstriction that may be epicardial, but we're not interested here because we're talking about microvascular, or maybe a constriction of the microvasculature, which entitles you to define microvascular abnormalities. So trying to put these together, we now have at least two big endotype chapters. We have coronary macrovascular disease based on the CFR and IMR, and then we have vasospastic microvascular angina, basically based on acetylcholine, although not specified here, surprisingly. Now, is it worth going through all this hassle? You know, there are some, we heard Professor Rosano say, you know, let's not revascularize for everyone nowadays, partly because these procedures do have disadvantages and side effects. They have radiations, they have complications, the acetylcholine can induce arrhythmias, bradycardias, etc. We're beginning to see a bit of hard data that tells us that, yes, in terms of patient with persistent refractory symptoms that really has impaired quality of life, even in my view, and I'm not an interventionalist or an angina person since decades, if you go into the details and are able to characterize the endotypes, you're able to treat patients more effectively and to improve their quality of life. This was done in a rather small but significant randomized trial called Cormica. Now, if you really want to be critical, you could still say, I'm not happy because I've looked at one coronary, I've refrained from putting acetylcholine in the right because I may go into severe bradycardia. So what may be missing? Maybe the LAD is fine, but I have microvascular dysfunction elsewhere. So some people sort of criticize the invasive coronary testing as being too regional and as missing a global coronary flow capacity, which indeed brings the non-invasive tests the most modern, like a positive emission tomography, cardiac magnetic, to the upfront, because they indeed have the capacity to measure all coronary territories and even to measure absolute flow, as we said, by PET, for instance. Now, is it apart beyond the quality of life of the patient, or am I really at risk if I have a chest pain that is considered of microvascular origin? This is a very much quoted paper, Jesperson et al. It shows what? In blue, you have the normal asymptomatic normal coronary arteries. In yellow, orange, you have the normal coronary arteries. These are event-free survival or pretty hard endpoints. And you can see it's really very graded, because then in green, you have the diffuse non-obstructive, and then you have the 1, 2, and 3 vessel disease that in this paper, which is quite large, they're not significantly different, but I think we agree that it's a graded increased risk of MACE in patients that go from angina and normal coronary arteries to NOCA to 1, 2, 3, and vessel. I'm concluding, yes. This is the ELS registry that I meant to say. And the important thing here that I want to say is that those that had non-invasive testing that was negative, but yet had coronary microvascular dysfunction, had the worst prognosis according to this registry. Now, to conclude, the rest is related to treatment. I'm very happy that Professor Rosano went into the details. Here you find more, because unfortunately it merits a presentation on its own. Here you have all the possible combinations and mechanisms. Here you have the important concept of the comorbidities and perhaps some considerations. And these are my final slides. I believe in the future we have probably almost the duty to try to improve harmonization of definitions, epidemiology, and diagnostic protocols of microvascular angina. Consider realistically feasible diagnostic testing in global current clinical practice. Test innovative metabolic polypill treatments for microvascular angina with reproducible and meaningful outcomes. And these indeed are some trials that are ongoing. Thank you very much for your attention.